Dear esteemed veterinarians, a very warm welcome to today's session on radiographic diagnosis of lung pathologies in pets, a clinical case-based study. We are honored to have with us our distinguished speaker, Dr. Arun Anand, whose insights continue to guide us and inspire the veterinary fraternity. I am Dr. Vishal Sharma, a proud veterinarian and managing director of Orihill Life Sciences. As a practicing vet myself, managing two pet hospitals in North Delhi under the name Pets Planet India Pet Hospitals Private Limited, I truly understand the ground level challenges, hopes, and responsibilities we all carry. Buy a vet for the vets, a mission close to my heart. It gives me immense pride to share that Orihill Life Sciences has grown into one of the India's leading manufacturer of veterinary pharmaceuticals with a product profile of 180 plus products. But beyond numbers, what truly defines us is our purpose. We are a company built by a vet exclusively to serve the vets. Everything we do, be it innovation, education, or support, is centered around empowering our veterinary community. We are here with safe, trusted, and first in India veterinary solutions. Our product portfolio includes herbal medicines, India's first 100% safe, sugar-free, and side effect-free formulations, safe even for newborn pups and kittens. Nutraceuticals, pharmaceuticals, injection, and grooming solutions, all carefully formulated for better compliances and outcomes. Breakthrough formulations, including meropenem injections, ferropenem tablets, alprazolam suspensions, tramadol suspensions, furosemide suspension, metazobine suspensions, and many more were first launched by Orihill Life Sciences for the first time in India. A robust range of neuro, cardiac, ophthalmic, dermatology products tailored for small animal needs. Strengthening veterinary knowledge across India. Under our initiative Buy a Vet for the Vets, we have created one of the largest platforms for continuous veterinary education through regular webinars. We aim to spotlight advanced yet often unexplored topics like feline medicine, cardiology, neurology, radiology, ophthalmology, and many more, because knowledge remains our most powerful tool in saving lives. Your support is our lifeline. Friends, this journey is only possible because of your unwavering support. We humbly request you to support this mission in whichever way you can. Even a small order, a word of encouragement, or referring us to a fellow vet, each gesture keeps this mission alive. Ordering is quick and effortless. Just call or text us on the number mentioned in the chat box. Our team will personally connect with you to take your order. We deliver directly to your clinic, no middleman involved. 100% all benefits and support go directly to you, and we promise highest trade margins to the vets. Let's walk this path together to grow, to learn, and to raise the standards of veterinary care across the nation. Thank you for being with us and for being a part of this journey. Warm regards. So here we welcome Dr. Arun Anand today as a speaker of this series. Dr. Sir, are you here?
Am I audible, sir?
Yes, sir. Yes, sir. Fully audible,
Okay.
sir.
Yeah.
So Dr. Arun Anand completed his graduation and post-graduation from Punjab Agriculture University, Ludhiana. He acquired doctoral degree from Guru Angad Dev Veterinary and Animal Sciences University, Gadwasu, Ludhiana. He joined as assistant professor in the Department of Surgery and Radiology, Punjab Agriculture University, and rose to the position of professor and head Department of Veterinary Surgery in Gadwasu. He acquired certificate qualification from Canadian Veterinary Medical Association. He also cleared Education Commission for Foreign Veterinary Graduates, ECFVG program USA, and registered as DVM with Michigan State Board of Veterinary Medicine USA. His main field of works are in urogenital surgery, joint surgery, oral surgery, especially small animal endodontics, emergency surgical procedures, soft tissue surgery, and small animal radiography, etc. So let's welcome Dr. Arun Anand. Thank you so much, sir, for being here.
Thank you, sir. Thank you. Thank you for giving me the platform to interact with all the vets from India. I can see a number of vets are have joined us. I welcome them all.
And its number is continuously increasing, sir.
Continuously increasing, yes. So
actually, sir, there is a little announcement, sir. As I have told you, Today, there are 2 emergency surgeries are going in my OT right now. So I may have to step out for something like, if somebody calls me for the help. So Kanika, Mrs. Kanika Sharma, CEO of Orihill, and my staff is there in case any problem occurs. And otherwise, I'm here.
Okay. Okay, we'll manage. No problem, sir.
Yes, sir. Yes, sir.
Okay, should I start with the webinar?
Yes, sir. Sure, sir.
Okay.
Please.
Let me start. Okay, I welcome all the participants who are come all the way from different parts of the country to join us as in this webinar. So myself, Dr. Arun, I'm working right now as a professor and head in veterinary surgery department, Guru Angad Dev Veterinary Animal Sciences University, Ludhiana. So today my topic will be on radiographic diagnosis of lung pathologies in pets, a clinical cases-based studies. So in this, as everyone knows, a lung is very important part of the body, and it's one of the vital part, and is also prone to a number of problems. So there are some conditions are there in which only the lungs are involved, or there is some other organs are involved. They also affect the lungs. So in these conditions, the lungs they will have some alterations, and these alterations or disease processes will show up as differently in the radiography. So my today the webinar will be on these patterns, like what are the different diseases which can lead to alteration in the pulmonary parenchyma. So there are basically 6 patterns which I'll be discussing. So all these 6 patterns will be discussed in detail, and after each pattern, I'll be telling you about the case studies as well. So different case studies, history, physical examination findings, and then I'll show you the X-rays, and then I'll discuss in detail about those X-rays as well. So one thing I must tell you that radiograph will tell you about the gross changes. Radiography is not the final diagnosis. So further we might have to go for further. So but extent of the change inside the lungs is very good, is excellently depicted by the radiography, and radiography is a very good tool, especially for the thoracic abnormalities, where the ultrasound might fail, but radiography can tell you a lot of things. But you should know how to see those anomalies, how these conditions. So there are a number of patterns which I'll be discussing. Let's start with the webinar. So aim of my presentation will be to describe the normal thoracic radiography. So I'll be showing you that how the normal radiography and what is the topography basically, where the particular lung lobe will be located. Because in the X-ray you can't delineate the cranial lung lobe or the caudal lung lobe or right side lung lobe or left side lung lobe. So there I will be telling you about where to see which part of the lung. So first part will be to describe the normal radiography, then diagnosis and differential diagnosis of the various lung patterns. This is very important that I told you in the beginning that lung patterns are the changes which these lungs they will show radiographically, and how to diagnose different and what is the differential diagnosis of these lung patterns. Then clinical cases based radiographic studies of the commonly presented lung pathologies, because I have seen especially like a number of my fellow vets, they send me the X-rays, but sometimes they miss a few things, and these few things like clinically based studies I'll be sharing those studies which can help you in your practice as well. So let's start with the normal. This is a normal large dog. If you see that I extrapolated with a different, like there is a one vein, this is a pulmonary vein, although like I'll be repeating the few things from the previous webinar, but this is very important to begin with, because you should know where the particular, because veins and arteries, they are very important part of the radiography. You have to look into the changes in these veins as well, and we call it as a vascular pattern. One of the 6 pattern is a vascular pattern, where you have to look into these blood vessels, and there is a aorta is there, and then the caudal vena cava at this place. So these are 4 structures which we should look any change as well. So and then there is a retrosternal region is there. Another is there is accessory lung lobe. Accessory lung lobe will be visible in between the diaphragm and the cardiac shadow. And there is a there is a lumbo-diaphragmatic angles are there. This is also very important because if there is any change is there, so that will be visible. So let me do the marker first. So if there is any change, especially if there is a cardiac in region, any anomaly or any heart disease is there, so this part of the lung we have to concentrate. So this is called caudal lung lobe. And if there is any there's a pneumonia is there, or aspiratory pneumonia is there, or bacterial pneumonia, or interstitial pneumonia is there, then this part of the lung has to be concentrated. Then there is another structure. This is the line which I showed. These are the caudal lobar blood vessels are there. So you should able in normal healthy dog, you should able to see these margins of these blood vessels. If these margins are not visible clearly, it means there is some lung pattern is there. Then you have to diagnose which type of lung patterns can be there. There is basically anatomically, if you recall your anatomy class, like there are 3 lung lobes are present in the right side of the thorax, and in the left side of the thorax it has a 2 lung lobes, because the left side has to adjust the heart. So nature has provided 2 lung lobes in the left side and 3 lung lobes on the right side. So there is an additional right middle lung lobe is there. So I'm talking about this right middle lung lobe. So in lateral view, the right middle lung lobe will not be visible in lateral view. So it will be demarcated, or it will be overshadowed by the cardiac shadow. So that's why if any lung pattern is visible over the cardiac shadow, it means that right middle lung lobe is affected to that particular disease. There is another structure which is very important. This is called cupula. So cupula, this is the pulmonary cupula. This is the structure. This is basically a pleural extension of the left part of the lung inside the neck through the thoracic inlet. So if there is any injury at the thoracic inlet, so the air can enter through this cupula into the pleural cavity, and that can lead to pneumothorax as well. So I'll be discussing in detail about these things as well later on. So let's talk about the normal anatomy. If you look into this one, so this is on the upper side. If you see here on the upper side, so this is a normal how the lungs will be. So this is right cranial lung lobe will be visible at this point. So when I'll be talking about the right caudodorsal lung lobe or caudodorsal or caudal lung lobe, so it means I'm talking about this part of the lung. Then right middle lung, as I already told you, it will be covering, or it will be extrapolating over the cardiac shadow. Then cupula pleura, this is extension which I already discussed. This will be visible at the number 4 position. Then accessory lung lobe. So accessory lung lobe will be visible in between the cardiac shadow and the diaphragm. So that's why if you know about the topography of these lobes, then if there is any lung pattern is visible, then you can easily assess that which part of the lung lobe is involved. So if you look into the left side, so left side has, as I told you, it has a 2 lung lobes, cranial and caudal lung lobe. So cranial lung lobe has a incomplete partition. So it has a left cranial lung lobe, but the cranial portion is there, and left cranial lung lobe has a caudal, means incomplete. If you see at this point, so this is incomplete division of the left cranial lung lobe. And there is another left caudal lung lobe. So it's almost the same, like it looks like a right caudal lung lobe. And the cupula pleura is another structure, and accessory lung lobe is at this position. Means right lateral and left lateral position means like almost looks like the same. When you see about the VD or DV view, so VD and DV view, if we demarcate the different lung lobes, so here at this point, right cranial lung lobe will be visible. So right cranial lung lobe, left cranial lung lobe, but it's a cranial portion will be at this point, and the caudal portion of the left cranial will be at this point. So means almost in the mid part of the heart, cardiac shadow. So right middle lung lobe. So if there is like here at this point, point. So right middle lung lobe is there. So any disease at this point, at this portion, will be shown up. It means like right middle lung lobe is involved. So right caudal lung lobe, and this is the left caudal lung lobe, and here will be the accessory lung lobe. And you can see the right and left caudal lung lobe, they will be overlapping the diaphragm as well. You can see they will be overlapping the diaphragm as well. So here whatever the disease process is going on, it will be shown up in the right caudal and the left caudal lung lobes. So another point which I want to highlight right now, that at least you should take two views, at least lateral view or VD or DV view. But if you take right lateral and left lateral both, so that will be an additional benefit as well. So there is one structure which is commonly visible in young dogs, which is less than 1 year of age. This is a thymus. If you see left side, this is left lung lobe. So left cranial lung lobe will have a structure. This is thymus. This is not an abnormality. If a dog which is less than 1 year of age has this structure visible in the X-ray, it means the thymus. This is a normal structure. After 1 year of age, this thymus will be replaced by the fatty tissue. So then it will not be visible. So in the cats, if you see, there's a little bit difference is there. So cat, there is a like caudal lung lobe is little bigger than the dogs. But there are few conditions which I'll be discussing later on, that you have to see in the caudal lung lobes as well, especially the asthma. The cats, they are prone to asthma. So there will be a lot of changes will be going on. So another thing which I want to tell you right now is that if there is any pneumonia is there, so this is part of the lung will be, you have to concentrate. And if there is a pulmonary edema, cardiogenic pulmonary edema, then this is the portion you have to look for, and most of the changes will happen in the caudal part of the lungs. So this is how the VD view will look in a normal cat. So let's come to the second part. This was about the normal lung lobe. Let's come to the second part. These are the lung patterns. Lung patterns means these are the changes in the pulmonary tissue because of some disease conditions. So these lung patterns, first one, I'll be discussing the bronchial pattern. Bronchial pattern means like normally the bronchi or air alveoli or these bronchi will not be visible in a normal X-rays. But if there is any calcification or inflammation of the bronchi, or there is some fluid accumulation around the bronchi, then these bronchi will start visible, calcification as well. So they will be started visible into the X-rays. And even in a normal aging process will also lead to bronchial pattern. Means the dogs which are more than 9 years of age, they will show up as a bronchial pattern, and this is a normal aging process. So that's not a disease process, but that will be the mild bronchial pattern. But if in a young dog or the dog which are middle age and having a bronchial pattern, which I'll be discussing later on, so they show up, then there is a disease process there. So differentially diagnosis has to be done why there is a bronchial pattern is there. Then second one is the unstructured interstitial pattern. So I'll be discussing that in the unstructured interstitial pattern as well. Then nodular interstitial pattern. The fourth pattern which I'll be discussing is the alveolar patterns. And then it will be the vascular pattern, which is normally seen whenever there is a heart disease or heart failure is there. Then vascular pattern will appear in the pulmonary parenchyma. Then sixth pattern will be the mixed pattern, when any of the two or more than two pattern will be visible in single radiograph, then we call it as a mixed pattern. Then let's start with the first lung pattern, which is the bronchial pattern. So bronchial pattern, normally I told you that bronchi, they normally are not visible in X-rays. So but can be only seen if they have some disease processes which led to the thick-walled bronchi, mineralized bronchi, or it's a dilated bronchi is there. Means bronchiectasis is there. So then these bronchi will be visible. So if you look into this picture, if you see, these are the bronchi. Normally when it is a diseased process is going on, then it will appear as a tram lines or donuts. Tram lines means like a railway lines, tram lines. So thickening or calcification or inflammation or fluid accumulation or metastasis of the bronchi, they will appear as a tram lines, and or it will appear as a donuts. If you see that radiographically a bronchial pattern appear as abnormally thick bronchial walls or peribronchial tissue. So bronchi which are perpendicular, this is very important. The bronchi which are perpendicular to the X-ray beam path will appear as tram lines. I'm talking about these ones. These tram lines will be shown by those bronchi which are perpendicular to the X-ray beam, and the bronchi which are parallel to the X-ray beam will appear as donuts. It doesn't mean that donuts will have a different pathology and tram lines will have a different pathology, but it's all because of the orientation of these bronchi. It will either appear as a tram line or it will appear as a donuts. So basically the pathology is the same. It's a bronchial pattern. So abnormally thick bronchial wall or peribronchial tissue result from fluid accumulation, cellular infiltration, mural hyperplasia means wall hyperplasia, hyperplasia of the bronchi, or mucus gland hyperplasia, or if there is excess of mucus is there, means there is some disease bronchitis, or there is alveolitis or interstitial pneumonia is there, or bacterial pneumonia, viral pneumonia is there, respiratory syncytial virus like that. These type of diseases, they lead to lot of mucus formation, and when that mucus formation comes into the bronchi, so there will be thickening, and that will be shown up in the X-rays. So all they will have a similar radiographic appearance. So if you differentially diagnose, means there are different diseases that can show up as a bronchial pattern. So bronchial calcification, this can be a normal aging process. As I told you, like more than 9 years of age dogs, they can show up as a bronchial calcification, and it's a normal. And chronic bronchitis, especially in the cats. So cats which are chronically bronchitis is there, which we call it as asthma. So they will show up. So I'll be showing you those X-rays as well. So chronic bronchitis, any allergic bronchitis, especially the seasonal bronchitis, or throughout the year there is allergic bronchitis is there from the pollens, from the mites, or from any other allergen is there. So that can, when it is inhaled, so it can lead to bronchitis, and it can show up as a allergic bronchitis. Then parasitic, sometimes the lung worms are there. In India, there is a lot of lung worms cases are there. Although like heartworm cases are not so common in India, but northeast part of India, they can have a heartworm. So when migration of these worms through the pulmonary parenchyma, so there can be an eosinophilic response by the body to that parasitic migration, and that can lead to the bronchial pattern as well. And some irritant is smoke inhalation is there, lot of pollution is there, especially in the winter season, lot of pollution. So when these smoke inhalation can lead to irritation, and that can also lead to the bronchial pattern. And there is a chronic bronchopneumonia because of the bacterial, viral, fungal, these region that can also lead to. So this was about the bronchial calcification. And peribronchial infiltrates means whenever, because of some allergens or because of some parasitic, when the eosinophil, they start accumulating and they come into the pulmonary tissue, and that shows up as a pulmonary infiltration of eosinophilia. We call it as PIE. So these infiltration, when eosinophilia will start, so there will be inflammatory process will be there, and these inflammatory process when start, so it will start appearing, and the bronchial pattern will be prominent in these ones. Okay, so the previous X-ray, this is the X-ray which I'll be discussing in next 2 slides. So these are, if you look into this one, so especially concentrate on this part, or concentrate in this part, and especially there is a pneumonia at this part as well. So if you look into this one, so let me highlight this portion. This portion I'm going to highlight. So here it is. So if you look into the arrows, white arrows, you will see that there are some structure which is parallel structures are running. So these I'm talking about these parallel structures, and another is I'm talking about these structures. So these structures are the bronchi. So which they should normally not be visible. So bronchial pattern is there, and this is because of bronchitis, some bronchial pattern. And another arrowheads, if you see these round structures, if you look into this one, let me highlight. If you look into this arrowhead, if you see there is one. Here is the bronchi, and there is a white structure surrounding this one. You can see this is thickening of the bronchial wall. These are called donuts. So if you see, like if you go to the bakery, the donuts will look like this structure. So donuts, that's why it is called donuts. And these are looks like a railway lines. So that's why it is called tram lines. So tram lines and donuts. These are the two characteristics of bronchial pattern. Another thing, if you see, so here is the cardiac shadow. This one is the cardiac shadow. I'm talking about this cardiac shadow. If you look, and this portion of the bronchi is overlapping the cardiac shadow. It means the this bronchial pattern is present in right middle lung lobe. Probably if you, I already discussed in the initial slides. So right middle lung lobe has a moderate to severe bronchial pattern is there. Okay. So then this is a mild. If you look into this one, here you see the bronchi and surrounded by the white structure. This is all mucoid or mucus accumulation around the bronchi. Here too, if you see, there is a bronchi. These are the donuts. These are donuts. If you see, here is the donuts, and here is the donuts which I'm talking. And this is a mild, and that was a moderate to severe bronchial pattern. And here is the mild bronchial pattern is there. It means that there is a mild disease process is going on, which is irritating the bronchi, and there is mild bronchitis is there. Okay, so this is the bronchial pattern in a cat. This is the cat which was having asthma, and asthma signs in cats is almost like a human. So they have they have open mouth breathing, frenetic episode of inhaling the air. So same the X-ray will, like, if you look into this, is just compare with the normal cat. If you look into the caudal part, if you look into the caudal lung lobe, and if you see here the diseased lung lobe, if you see there are number of donuts are there, but in normal cat the donuts are not visible. And if you see at this point, these observe the increased size and even increased size of the caudal lung lobe, means the gap between the diaphragm and the cardiac shadow, it has increased, and there is a flattening of diaphragm because of the expiratory dyspnea. So all the diseases which are having a lower lung disease, so they have expiratory dyspnea. So whenever the animal or the cat will have an expiratory dyspnea, there will be the flattening of the diaphragm will be visible as well. So this is a sign of asthma in cats. So here you see this film will show up a diffuse bronchial disease in cats, and you can see the pair. Let me highlight here. These are the bronchi which I am highlighting. Let me highlight again. I think calcification and bronchitis, bronchial. So on the end there is a donut patterns are there. So these are the tapering. So these are tram lines and the end donuts. So these are here too. There is another bronchi. So these are the donuts. So these are typical signs. So normally, if you see why the cats, the dogs, they rarely have asthma. Maybe sometime occasionally can have asthma, depending upon if the dog is constantly exposed to some allergens, they can have asthma as well. But the cats, they are more prone to asthma because the reason is there is a more smooth muscles surrounding the periphery. So that's why the bronchospasm is more as compared to, means bronchospasm is more in cats as compared to the dogs. And another thing is dogs too have an extensive network of mucus glands around around the alveoli and the airways as well. And whenever there is some bronchitis is there, so that can contribute, or inflammation is there, so that can contribute contribute to the airway mucus, and ultimately it leads to constriction of the bronchi. When it leads to the constriction of the bronchi, so that leads to asthmatic signs. So that's why the cats, they are more prone because of the smooth muscles around the peripheral airways, and secondly they have more mucus glands which they secrete a lot of mucus when there is inflammation is there. So even you can see, yeah, these double arrow, you can see the space between the diaphragm and the cardiac shadow, that also increases. This is another sign that there is a lot of effort is there by the cat to inhale the air. So ultimately it leads to the flattening of the diaphragm. Let's start. This was about the bronchial pattern. So this is how it looks. So now I'm going to show you about 5 to 6 bronchial pattern case studies. So there's a 1-year-old female husky that shows increased respiratory effort with hacking cough is there. Hacking cough. This is another important sign in a history as well. So lateral and VD views will be in the next slide. So observe the terminal part of the trachea carefully in the lateral view. So let me put you the X-rays. So if you look into this, I'm talking about the terminal portion, means I'm talking about this portion. I'll be talking about this portion. So here it is. So let me highlight. So here is the trachea. Here is the trachea. So there is a soft tissue density which is present in the terminal portion of the trachea. So honking cough means inspiratory honking cough is there. I told you, like whenever there is a lower lung disease, then it's expiratory dyspnea, and whenever there is a upper respiratory disease, then there is inspiratory dyspnea is there. So honking cough as well as inspiratory dyspnea was present in this. And so observe the numerous small tissue masses like opacity at the terminal part of the trachea. So and even you can note down the thickening at this point. So here is the donuts are there. So thickening of the caudal lung lobe. So these changes are consistent with the lung worm infestation. So this is called verminous pneumonia. So it means like lung lobes, these X-ray will tell you about the changes. So further diagnosis, what you have to do is clinical signs which are not responding to the chronic cough. Radiographic signs are like that. And when you go for fecal examination, you found that larva of the lung lobes, lung worm is visible in fecal examination. And when you start with the enthelmintic and that respond to the treatment, then it can be a diagnosis of verminous pneumonia as well. Or another thing, if you can go for further diagnosis, you can go for bronchioalveolar lavage. So when you go for bronchioalveolar lavage and when you take out the sample and see, there can be the worms can be seen in those bronchioalveolar lavage as well. But fecal examination can give you the additional diagnosis as well without going for any invasive procedure. So here the donuts are there. So this is the same one. If you see, there is another case which was having a lung worm. So and this is after the treatment, and you can see the difference in the two. So in the lung worms, the upper X-ray, there is more radiopacity. Lung bronchi are more visible, more highlighting. You can see here the lung pattern, bronchial pattern is visible. Here the bronchial pattern is visible. So which is less. So this is after the treatment here. So it was like lung worm which was seen at this point, and you can see at the same point, that point it has healed up after the treatment. So enthelmintic treatment was given in this dog, and this is a lung worm. So now comes to the clinical case number 2. This is a 1-year-old CU has a chronic productive cough since last 6 months. So lateral views is as follows. You can see at this point, so there is a lot of whiteness is there. So here you can see there is a bronchi. So whiteness, calcification of the bronchi is there. So calcification of the bronchi at this point. So calcification of the bronchi, donuts are there. So if you look, the trachea, this is the trachea. So if you have to see the my previous webinar, so there I highlighted the trachea in the cardiac issues as well, but now you can see the trachea in the VD view, and here is the two bronchi. So if you see the bronchi at this point, if you see there is a calcification of the bronchi, whiteness, calcification of the bronchi is there. So there is a severe bronchial pattern. So radiographic findings is there is a severe bronchial pattern, a diagnosis of allergic or inflammatory bronchitis. So a transtracheal aspirate was taken in this dog, and there was a numerous eosinophilia was there also. And even in the, it has been seen that this dog was having a eosinophilia in CBC, complete blood count, when peripheral blood count was done. So that CBC, there was when cytology was done. So there is a lot of eosinophilia as well. So there was increased serum globulin, and that is serum globulin indicates that there is some chronic diseases going on. Dogs was dizzying, tire easily, or cyanosis. Even cyanosis was seen at rest. So bronchial exudate was also having, means when bronchial exudate, animal cough some exudate, and when it was applied on the slide, or even the nasal swab was taken, when it was applied on slide, it was also having a eosinophilia as well. So in the end, you can see the chronic bacterial, viral, fungal, allergen, or migrating worms. They can also be the cause. They can be cause of eosinophilia, pulmonary infiltration of eosinophilia. Means you can see the eosinophils have infiltrated into the pulmonary parenchyma because of any of these causes, because of the bacteria, viral, fungal, allergens, migrating worms, especially the lung worms or heart worms. So they can lead to the eosinophilia. This is the same dog. I'm talking about this dog. This is the same dog. So after treatment, when X-ray was taken, you can see the same dog 2 months later after treatment with corticosteroids, and you can notice the improvement. But still there is some residual thickening, some bronchial thickening is there still present. It means we might have to continue with the anti-inflammatory and corticosteroid for some more long periods as well. So this is another case. So this was a severe bronchitis which recently presented to our hospital. So you can clearly see all the bronchi, and here you see another case with severe bronchitis due to the pulmonary infiltration of eosinophilia. So here you see the donuts. If you see the donuts, here you see the donuts, and these are numerous donuts are visible. So these are the tram lines. If you see the tram lines, and even a number of tram lines are visible. So even the tram lines is visible over here as well. So here is the tram lines. Even donuts, a big donut is visible at this point as well. So you can see how the pulmonary infiltration of eosinophilia. So this is the same dog, which is a VD view. So you can see the a number of donuts are visible. Here you see the donuts are visible. Here is the donuts are visible. So these donuts, they are characteristic of the bronchial pattern. This is a big donut is there. Here 2-3 donuts, they are all together. So this is the bronchial pattern. So now comes to the third case of the bronchial pattern, the 12-year-old male mixed breed, chronic cough, sometimes productive, occasionally wheezing is there. There is whistling sounds when you auscultate. Next slides will be the thoracic. You can see here, if you see, there is a bronchi. If you see, like, let me highlight multiple times so that you can have an idea. So normally the bronchi of this big size is not visible at this point. Okay. So here you see the donuts. There is another donuts is visible. So a number of donuts are visible. So my idea is that to tell you that these big bronchi is visible in the caudal lung lobe. Normally it should not be there. So let me tell you like why it is present. So when we took the X-ray of the lateral view of this animal, and I'll be enlarging this part of the slide in the next slide as well. So if you see, so on the caudal side, there is a big bronchi is there. If you see, like so there is a diffused allied bronchi with the bronchial thickening and sacral dilatation of the bronchial lumen, which indicates bronchiectasis. Means caudal lung lobe, or I'll say accessory lung lobe and caudal lung lobe, they have the big bronchi. This is the big bronchi. Normally it should not be there. When it is there, it means it's a bronchiectasis is there. Bronchiectasis means this is an end stage condition of the bronchi resulting from the long-term chronic inflammation. So here you see, so this is irreversible changes are there. So here you see the big bronchi, and there is these are the bronchi, caudal lung lobe also have, and these are the walls. These are the mucus secretions in within this bronchial. So this is a case of bronchiectasis. So big bronchi in caudal to the cardiac shadow, or in the caudal lung lobe or the accessory lung lobe. This is the diagnosis will be the bronchiectasis. So now comes to the fourth clinical case, 6-year-old cat which is coughing since last 6 months. Okay, coughing and is not responding to the antitussive or cough treatment. So then the first thing you should come in your mind, let's take an X-ray that whether whether this cat might be having asthma and can chronic bronchitis may be the cause. So let's take the slides. You can see. So if you look into this one, especially if you look into this caudal lung lobe, I'm talking about this one, caudal lung lobe. And if you see, there is one congestion of the lung here as well. So this lung lobe, which I highlighted right now, this is the right middle lung lobe. I'm talking about here, I'll be highlighting. So if you compare, just compare with the normal one. So there is this is a typical, see the flat diaphragm, totally it's a flat one, like a flat structure. So this is these radiographic signs is an indication that this cat is having asthma. So here too, so if you look into this structure, this triangular structure, so this one, so this is the right middle lung lobe is having a congestion as well. So this one, so right middle lung lobe is having a congestion. So there is a severe diffuse bronchial pattern in lateral consolidation. So report will be the severe diffuse bronchial lung lobes in the lateral view, consolidation of the right middle lung lobe in the VD view. So there will be a flattening of the diaphragm. So chances of severe bronchial disease as well as asthma is there. So mild asthmatic episode, they will show up as a chronic wheezing and coughing. But if there is a severe asthmatic cats, then there will be expiratory dyspnea, cyanosis, pharetic attempts to obtain the air, open mouth breathing, and sometimes when the animal wants the air, so there will be attempts to obtain the air as well. So these are the typical sign of asthma in cats. So now comes to the second, this was the first lung pattern. Now comes to the second lung pattern. This is called unstructured interstitial pattern. So unstructured interstitial pattern means this pattern will appear as a linear, means reticular, or it will appear as a nodular, or it can be appear as a reticulonodular. So I'll be showing you all these X-rays in next case studies. So normally, what is the interstitial? You might have heard a number of terms like there is interstitial pneumonia is there. So it means interstitium. There is the interstitium is basically a space which is present between the alveoli and the blood vessels which are surrounding the alveoli. So there is not a direct contact between the alveoli and the blood vessels. So exchange of gases, they will take place through this interstitium. So interstitium basically it has a collagen as well. It has a little bit fluid in it. It has a pericyte. Some cells are there. So normally these interstitial structures, which includes the alveolar walls, the bronchial walls, interlobar septa, or some of the tissue. So some of the vessels are there. So these are not visible in X-rays. So when these started visible, when you start seeing the interstitial pattern, it means there is some disease process is going on. So let me come to the slides. So I'm talking about this interstitium. This interstitium, so here is the blood vessel, this is the blood vessel, and here is the alveoli, this is the alveoli. So in between the alveoli and the blood vessel, there is some gap is there or structure is there which is called interstitium. So this interstitium normally they help in exchange of the gases. Oxygen will enter into the bloodstream and carbon dioxide will enter back into the alveoli. So so whenever there is some disease process is there, just for example, there is interstitial pneumonia is there. So ultimately what happens, the blood vessel walls, these alteration in blood vessel walls happen. So slowly and slowly the extravasation of the fluid from the vessels enter, that fluid start entering into the interstitium. And this is non-cardiac regions. There is another disease of cardiac region which is called left side heart failure. When left side heart failure is there, then there will be a congestion of the blood within these vessels. Means blood vessel, because there is a the heart is not able to hold the preload as well as afterload. So ultimately the blood start congesting into these blood vessels. So that leads to extravasation of the fluid into the interstitium. So extravasation of the fluid, these extravasation of the fluid into the interstitium. So that leads to interstitial, unstructured interstitial. This is called unstructured interstitial. So this can be cardiogenic in origin or non-cardiogenic in origin. Any virus, bacteria, fungus which lead to alteration in these vessels wall, so that extravasation of the fluid from these blood vessels into the interstitium happens. So ultimately it leads to the unstructured interstitial pattern. So there will be increase in the fluid cells, fibrin content in the interstitial fluid that make the interstitium more evident radiographically. Also, there is a decrease in the lung volume that make the interstitium more evident. Means normally the interstitium will not be visible in the X-ray, but when it start appearing, it means there is unstructured interstitial pattern. Another thing is the blood vessels which are visible. If you recall my first few slides, so I told you these are vein, these are pulmonary vein and pulmonary arteries there, and there is a caudal lobar, all these vessels. So all these vessels margin will be clearly visible because of the air in the alveoli and the fluid in the blood vessels. But when the fluid also enters into interstitium, the wall of the blood vessels will become hazy. So there will be increased hazy lung opacity, obscured but not obliterated vascular margins. Means vascular margins will be visible, but their margins will be hazy. Here you see, so mild interstitial pattern. Here you see the mild interstitial pattern. So aorta is visible, but its margins are little bit hazy. So here you see the caudal lung lobe, margins are visible. These are the caudal lung caudal lobar vessels. So these margins are not so clear, but still it's a mild interstitial, unstructured interstitial. Here is the moderate. You just see differentiate between the normal lung and the lung which is having unstructured interstitial pattern. Unstructured, you can see the margins are not so clearly visible. This is unstructured interstitial pattern. So there is increased hazy lung opacity, obscured but not obliterated. Obscured means the margins are obscured, but you can see that here some blood vessels are going at least. So these are the vascular margins are not obliterated. Here the aorta is there. Here you can see the caudal vena cava, but the margins in a disease condition is not clearly visible. So this is severe interstitial pattern, means depending upon how much fluid from blood vessel has entered into the interstitium, the pattern also varies from mild to severe. If more fluid entered, so whenever such type of pattern is visible in the caudal lung lobe, so then you have to rule out the heart disease or heart failure. It means that dog or the cat can have left side heart failure as well. So such type of pattern, so has to be evaluated. Such patients has to be evaluated for the heart disease as well. So differential diagnosis. So if there is a diffuse pattern, if there is a one or more severe lung lobes are involved, so there can be a partial lung collapse or hemorrhage can be there even after accident. If after like trauma, hit by a car, fall from height. So if there is some trauma is there, so that led to the bleeding from the blood vessels, and that bleeding has entered into the interstitium. So that will also show up as a unstructured. So you have to correlate with the history history as well. So then bronchial from foreign body can also lead to unstructured interstitial pattern. So especially the important part is that edema. When there is a caudal lung lobe, which I showed you in the previous slides, caudal lung lobe. So when the edema is there, or whenever there is a unstructured interstitial pattern, so edema will be shown up as a unstructured interstitial pattern, and that is normally cardiogenic in origin. So pneumonia and hemorrhage, that I already told you about. If all lung lobes are affected, means if all cranial and caudal or accessory and middle lung lobe all are affected, then it can be a normal aging process. Whenever the dog crosses 8 to 9 years of age, the normal aging process can start. So it can have a thickened or calcified bronchi. It can have a diffuse unstructured interstitial pattern as well. So these are the normal aging process. Lymphosarcoma, this is a normal condition, this is a very common disease nowadays, lymphosarcoma or lymphoma as well. So this can show up as a diffuse interstitial pattern. So all these inflammatory causes, which can lead to pneumonitis, that can also lead to diffuse unstructured interstitial pattern. So as I told you in the beginning, that there are the X-ray, the radiograph will tell you only about the changes, but you have to differential diagnose and you have to go for further diagnosis as well. So these changes will be shown up in these disease conditions. Let's come to the clinical cases of unstructured interstitial pattern. Clinical cases. Let's come to the first case is the male Labrador, male, aged 9 years of, started showing exercise intolerance, dyspnea since last 2 months. No sign of syncope is there. It means heart disease may not be the cause, maybe, but you have to rule out, because exercise intolerance can be a sign of respiratory problem, or it can be probably disease, can be cardiogenic in origin as well. Lateral and VD view is as follows. So what are the lung pattern? If you see at this point, there is a severe interstitial pattern is going on. Severe interstitial, but this may not be because of heart disease, because if you look into the cardiac shadow, it is normal cardiac shadow, and trachea is normal. So this can be because of some disease condition. This can be because of even you can look into this one. This is interstitial, although this unstructured interstitial pattern is in the caudal lung lobe, which is a normal, in a cardiogenic edema, pulmonary edema, but this dog is having a unstructured interstitial pattern or pulmonary edema because of some non-cardiogenic injury. So here, if you see, there is one other one, there is another. These are all because you can see the blood vessels. Here you see the blood vessels. It looks like the blood vessels, caudal lobar blood vessels are there, but the margins are not so clear. Margins should be very clear because lungs have a very good contrast because they have a fluid in it, they have air in it. So all the blood vessels will be surrounded by the air. This is a good contrast. So margins should be clearly visible. When margins are not clearly visible, it means unstructured interstitial pattern is there. Here you let me highlight. Note the unstructured interstitial pattern, obscuring the vascular margins, thus resulting in the interstitial pattern. But this is not alveolar pattern. So this is the next pattern which I'll be discussing. It means unstructured interstitial pattern is the first stage of alveolar pattern, which I'll be discussing. So let's concentrate only on the interstitial pattern right now. So here you see, so transtracheal lavage in this case, that was done, and it showed that a marked eosinophilia. I told you in the previous slides that even in bronchial pattern can also be shown as a pulmonary infiltration. Even the unstructured pattern, unstructured interstitial pattern can also show up as a pulmonary infiltration of eosinophilia due to immunological hypersensitivity. This dog was placed in the corticosteroid on tapering dose for 4 weeks and showed improvement in the radiography. This is the same dog. We show the radio. Now the margins are little bit more clear. Not complete resolution has not happened, but now the margins are little bit better as compared to the older one as well. So margins. So that's why. So you can compare it as well. Now comes to the another case, which is a 9-year-old Spitz having a respiratory distress. So lateral VD view is there. Here you see. So here you see this is called a cotton wool-like appearance. It looks like a cotton is there in the X-ray. This is a cotton wool-like appearance. So this is also a type of interstitial pattern, unstructured interstitial pattern. So here the same VD view of the same dog. If you see this is unstructured interstitial, this is called a retico-nodular pattern. So there is a reticular pattern, reticulo-nodular pattern, unstructured interstitial pattern. So this is a reticulo-nodular, means it looks like a cotton balls like appearance is there. So this is the case of granulomatous pneumonitis, fungal infection. Fungal infection is most likely, and the less likely can be because of the hemangiosarcoma and lymphosarcoma. They can also show up like these X-rays as well. But fungal infection is most likely. So 2-month antifungal with itraconazole, that show the improvement. You can see still there is still there is some disease process still there, some pattern still there. Even the margins of the blood vessel is not clearly visible, but still there is a lot of resolution is there from the initial ones. You can see from before treatment and after treatment, there is a resolution is there. It means fungal infection should need to be your first differential when such type of X-rays they are presented after taking an X-ray in a dog, like such type of X-rays are presented. 6-year-old male with acute liver, and this is very important. Whenever you take an history, you see acute liver and kidney disease is there on blood work, but there is a simultaneously dyspnea as well. Means you have to correlate everything for final diagnosis. Lateral and VD view, you see at this point, you see these are the all unstructured interstitial pattern caudally. So these are all unstructured. Here to the VD view, if you look, this is a diffuse reticulo-nodular interstitial pattern. So this dog was tested for the leptospira. Why I told you in before while giving the history that it was having a liver as well as kidney disease simultaneously. And when you see the X-rays, so when these type of reticulo-nodular, this is also a little bit cotton ball like appearance. So this is called leptospiral pneumonitis. Leptospiral, because some of the serovars, we call it as some of the types of the leptospira, they can also affect the lungs as well, and that can show up as a reticulo-nodular pattern, which is a type of interstitial, unstructured interstitial pattern. So 9-year-old Doberman female, which is having a history of tachycardia as well as heart murmurs. So X-rays are there. You can see the X-rays. So even you can see the aorta. Here the aorta should be there. Aorta is not visible. Caudal vena cava should be at this point. The margins are not clearly visible. Caudal lobar vessels, they are not clearly visible. It means there is unstructured interstitial pattern is there. So here to the unstructured interstitial pattern is there. So let me highlight this point. Right now, you see there is one even at this point, there is a pleural effusions are there. If you see the red one arrow, so this is these are pleural effusions. So and even there is these are unstructured. This unstructured interstitial pattern is basically because of the pulmonary edema. Pulmonary edema because of left side heart failure. So left side heart failure led to the congestion of the blood vessels. So congestion of the blood vessels, and slowly when stagnation of the blood vessels happen around the alveoli, extravasation of the fluid happens. So that leads to edema of the lungs. So this is a sign of left side heart failure. So there is a cardiomegaly, especially the left atrium and the left ventricle. You can refer to my last webinar to see how the left atrium enlargement and left ventricle enlargement will look. So there is a diffuse interstitial and bronchial lobar opacities as well. So there is an increased size of the cranial lobar. Here, cranial lobar, I'm talking about this portion. So you have to look into this one, cranial lobar. Vessels will be in right. So there is a small amount of pleural effusions. Here is shown as a line. So this is a sign. This is an example of congestive heart failure is developing, but early stage of left side heart failure. The edema and the pattern is interstitial. So more advanced will show up as a alveolar pattern. Means my idea of telling you is that whenever you look into this one, whenever you look into the caudal lung lobe, and if there is an unstructured interstitial pattern is there, so I'll be showing the advanced stage of the heart failure later in when I'll go towards the vascular pattern as well. But this is the initial stage, so it means this is left side heart failure because of as shown in a caudal lung lobe having unstructured interstitial. Let's come to the third lung pattern, which is nodular interstitial. So these type of nodular interstitial pattern can be because of primary lung lobe disease, or primary lung tumor, or primary lung disease having some tumor, or metastatic tumors. So both they will show up as a nodular interstitial pattern. So if you see these are here is the lung lobe. So these are round. So another thing which I want to tell you right now, so there will be a difference in the size. Here little bit bigger one, here little bit smaller one. So here also like a medium size nodules are there. So when the bigger, medium, small size nodules are visible, it means this is a nodular pattern. So this is either a primary lung disease, or it can be because of the metastatic lung disease. This is also known as structured interstitial pattern. And previous was unstructured. Unstructured means there is nothing is there, only there is a fluid is there. So that is why it is called unstructured. Here there is one structure is there with the nodule is visible. Nodule is present in the interstitial space. So that's why, because you know the lungs is a highly vascular structure. Highly vascular, all the body blood, they will ultimately for oxygenation will come into the lungs. So that's why if there is any neoplastic changes or a neoplasia developing, or any malignancy going on inside the body, so chances are there that malignancy will ultimately metastasize into the lungs. So when it will metastasize into the lungs, it will show up as a nodular interstitial pattern. So cluster of the cells that expand and displace the normal adjacent cells and can be seen. So there is one characteristic is there. Once the nodules are visible in X-ray, it means that will be visible only when the size of the nodule is more than 4 to 5 millimeter in diameter. Nodules which are less than 4 to 5 millimeter will not be visible in X-rays. It means if you are able to see the nodules in the X-rays, it means that is minimum disease, means 4 to 5 mm, more than 4 to 5 mm diameter is there. Small nodule may grow into the lung masses. Lung nodules may be as a solitary, diffuse, smooth or irregular margins, neoplasia, abscess, they will also appear. So solid nodules will be normally, it's a neoplasia or granulomas are there. But if there is cavitary lesions, I'll be showing you the lesion like that X-rays as well. If there are cavitary lesions are there, means a nodule is visible, but it has a hollow inside. Hollow inside means there is a fluid inside, means there is a radiolucent centering, but radio opaque, there is outer margins are there. Those are called cavitary lesions. So those cavitary lesions can be because of some abscess or some cyst, lung cyst, or can be because of lung bullae as well. So I'll be showing you those X-rays as well. So you can see numerous X-rays are visible. You can see these numerous X-rays, numerous nodules. You can see the big size nodules, small size nodules. So these are small size nodules are there. And even here you see small size. So this indicates that this is a nodular interstitial pattern. So numerous varying size nodules are visible. Here too you see these are the nodules. So here you see the nodules are visible over the cardiac shadow. It means right middle lung lobe has these nodules as well. Here the cranial lung lobe has the nodules as well. So you can see these ones. So these nodules are visible. This is nodular interstitial pattern. So these are the nodular interstitial. These again are the nodular interstitial pattern. So these are the different caudal lung lobe as well as the middle accessory lung lobe. All are having these nodular interstitial pattern. Let's come to the clinical studies of the nodular interstitial pattern. So a 10-year-old German Shepherd dog has a splenic tumor. Before surgery, thoracic X-ray was taken to see any metastasis. So whenever you suspect that there is some splenic involvement is there, some ultrasound shows that there is, or there is X-ray that shows there is a splenic enlargement is there. So always take thoracic radiograph as well simultaneously to see whether there is any metastatic lesions is there or nodular interstitial pattern is there. So metastasis, extent of metastasis can be judged clearly from the thoracic radiography as well. So here you see, so there is one big nodule was visible in thoracic. This is the same spleen. I'm talking about histories. If you see that there is a splenic tumor was there in the history when you see this one, but one nodule was seen in the right side of the thorax, not visible in the lateral view. This was not visible in the lateral view. But on physical exam, there was a round mass which was palpable near the thorax. Like at the level of thorax, near lateral to the thorax. So, but we were confused that whether this is intrathoracic or extrathoracic. So what we did is in order to differentiate, you can see in the lateral view there is no nodule is there. In order to differentiate, what we did, we applied barium over the nodule which was externally present. So the tumor or the growth which was on extrathoracic, when barium was applied, and now we saw that barium was visible over that nodule. It means this nodule is not intrathoracic, but it is extrathoracic in origin. Extra means outside nodule is there. So, an 8-year-old Labrador Retriever, 3 years ago, like abdominal radiograph and ultrasound of the abdomen showed round mass in the tail of the spleen, and splenectomy was performed. Histopathology of this spleen shows a benign hematoma. It was not a malignancy, was not there. Histopathology showed a benign hematoma. Now the dog is showing lethargic, dyspnea, tachycardia. So lateral view was taken to see whether this is any metastasis is there or not, or is there any changes there, nodular interstitial pattern is there or not. So when we took the X-ray, you can see there is a margin here. You see here is the cardiac shadow. Here is the cardiac shadow. There is one margin, the lung lobe. Here is the lung lobe, right middle lung lobe. This is congested totally. You can see. So there is a multiple varied sized soft tissue nodules. Here the soft tissue nodules. Here you see the soft tissue nodules, and this big nodule was visible throughout the lung. So this is a soft tissue mass in the right lung lobe. So this is most consistent with the primary lung tumor, because in histopathology that was the lung that was a only hematoma, splenic hematoma. But now this is a primary lung disease which appear as a big nodule interstitial pattern as well. So here the small nodules are visible. So a 5-year-old German Shepherd female is presented with poor appetite and lethargy. Blood work reveals hypercalcemia. So this is very important part of the blood work. Hypercalcemia is there. So thoracic radiography, when it was taken, you can see the trachea, how the trachea is traveling. So here the trachea is traveling dorsally. When it is pushed dorsally, it means there is some structure is there at this level which is pushing the trachea dorsally. Here you see that. So there was a small nodule which was present just below the trachea in the mediastinum. This is the cranial mediastinum. So which is pushing the trachea dorsally. This is pushing the trachea dorsally. And on lateral view, there is a mass in the cranial mediastinum with a dorsal displacement of the trachea. Here you see the mass is there. And the trachea is at this point. Here is the trachea. Here is the trachea. So this was in video mediastinum is widened as well. So here is the cranium mediastinum. It is quite widened. This is widened as well. So here. So most likely diagnosis for the mediastinal mass in a dog with hypercalcemia is lymphoma. So whenever there is although like 40% of the dogs 40% of the dogs with lymphoma will have hypercalcemia. But if the cranial mediastinal mass and there is hypercalcemia, then it's a definite diagnosis is that lymphoma, the dog is affected with the lymphoma. So cardiovascular structures are normal. So there is no other, any unstructured nodular interstitial pattern, nothing, only one nodule is present in the mediastinum. So one thing I must tell you that the structures which are present in the mediastinum are all the structures like trachea, like esophagus, mediastinal lymph nodes, aorta is there, except lungs. Lungs are present in the pleural space. Except lungs, all the structures of the thoracic cavity, they are present in the mediastinum. So that's why, like, whenever there is a mediastinal mass is there, so chances are there that the that lungs may not be affected simultaneously because it's enclosed in the mediastinum. So a 3-year-old dog which is having a bilateral swelling in the front, so front leg, the left front and hind leg, long bones. So radiograph. So you can see. Let me show you the video. Let me show you the video. Here. So here you see, this is the dog which was presented. You can see there is a big enlargement is there in the both front leg and hind legs as well. So now why I'm showing it looks like some orthopedic problem, but why I'm showing you the video, because the problem or the etiology was not in the orthopedic, was not in the radius or ulna or tibia or hind leg or front leg. It was in the lungs. So this is you can see the X-rays. This is the severe periosteal reaction is there. You can see the front leg. Here is the elbow joint. This is the elbow joint. So you can see. So this is called hypertrophic osteopathy. This hypertrophic osteopathy means a diffused periosteal bone reaction is there. Now, how we should proceed further for diagnosis means what is the cause? What we have to do is we have to go for X-rays. So you can see here. Here, if you see, there is a big nodule is there. So hypertrophic osteopathy is a diffuse periosteal proliferative condition of the long bones secondary to the neoplasia or infectious masses in the thoracic or abdominal cavity. So whenever such type of cases they come, which is having a hypertrophic osteopathy of the long bones having a severe periosteal reaction, then you must go for the X-ray of the thoracic as well as the abdomen. Most likely the etiological agent will be there in the thoracic cavity. So this is called pulmonary osteopathy is the cause for hypertrophic osteopathy. So 6-year-old dog with a history of a resection of the squamous cell carcinoma about 5 months ago, a thoracic X-ray was taken to check the metastatic lung disease. So this is very important case, so which I want to discuss as well. So let me show you these ones. I think like if you can appreciate these small nodules on the tip of the yellow arrows, these small nodules. In the VD view, you can see these small nodules. So from X-ray, it looks like a metastasis, but one thing I must tell you, this is not metastasis. How I'll explain in the next slide. So so this is not metastasis at all. So no evidence of pulmonary metastasis is seen in these films, although the nodules are visible. What happens? So if let me highlight this portion. So these are the on the red tips on the red arrow tips of the red arrow. You can see small nodules. So why? Now there is we have to differentiate whether this is a nodular or metastatic lesion or it's a normal structure. So if you observe these round nodules, these are almost of the similar diameter. They are not variable. I told you in the nodular pattern of when the nodules will be the variable diameter. But here the diameter of all the nodules are the same. So if you see in the second picture, the numerous vessels viewed end-on vessels. Let me see what are the end-on vessels. If you see this third picture, just concentrate on the third picture. You can see this is the parent. This is the parent vessel. From the parent big vessel, there is small vessels are coming up. So when these small vessels, these are the end-on vessels, when these vessels, they become parallel to the X-ray beam, they will appear as small nodule. And these vessels which remain perpendicular to the X-ray beam, they will show up as long lines. So same like tram lines or donuts I'm talking about. So these end-on vessels, and especially if you see these vessels, they are overlapping with the big vessels. So that's why right now, this is not a metastatic lesion. This is a normal structure. This is normal structure. The vessels that branch can look like a round appearance and end-on view. This is called end-on view. Here, this is called end-on view. So observe the small nodules in the second picture that overlap the big parent vessel. So here I'm talking about this vessel. This parent vessel is the big, and these small nodules, they are overlapping these vessels. These are not metastatic lesions. So this is who have sometimes some of the vets, they misdiagnose this as a metastatic lesions. This is not a metastatic by two ways. One is it overlaps the big blood vessel. Second, they are almost the uniform in the size. So that's why this is not a. So if you see this one, this is another X-ray of another dog, which are having small nodules, but they are not overlapping the big vessels. If you see, these are the big vessels. They are not overlapping the big vessels. They are present within the pulmonary tissue. These are here. They are present within the pulmonary tissue. So that's why these are the metastatic lesions, not the previous one. So not the previous one. So you have to see this one. So here you see they are not overlapping. So notice opacity. They are not end-on vessels as they are not along the parent pulmonary vessel. So here you see especially, even they are varying in size. Here, this one is the bigger one, little bigger one. Here is the smaller one. And here is the vessel which is going on. So they are not overlapping with the vessels. So now comes to the another part of nodular interstitial, which is called cavitary lesions. Cavitary lesions means they looks like a hollow from inside. So there is outer is radiopaque, inside is the radiolucent. So I'll show you the dog. Let me tell you about the case history. A dog has a chronic cough with a fever. TLC is high. Lateral VD view is this one. So this is the X-ray. So if you see at this point, so here is the lobar signs, means the congestion is there. So here is the congestion sign. So this is the congestion. It means there is some pneumonia changes are going on in the right middle lung lobe. And here you see the cavitary lesions, and like in between within that yellow square. So there is a thick walled air filled mass in the caudal lung lobe. This one, these are the margins. And here you see in the middle, it has it is a lighter in color, grayish opacity is there, radiolucency is there. Here is the radio opaque. Here is the radiolucency, and even you can see the thickness of the wall as well. So this is so here there is another nodule is there, and even small air pockets are there here as well. So if you see the VD view, these are cavitary lesions in the accessory lung lobe. So this is the case of lung abscess. So two lung abscesses were present. So one was in the caudal lung lobe, another was present in the accessory lung lobe, and there was a congestion, pneumonia of the right middle lung lobe as well. Here you see at this point right middle lung lobe as well, and here you see there is if you see look one the cavitary lesions. I told you that caudal lung lobes, right and left, they normally overlap with the diaphragm as well. So here you see the cavitary lesions. So thick-walled air-filled mass or even fluid-filled as well in the left caudal lung lobe, and this was a case of cavitary lesions. So these findings are consistent with the inflammatory lung disease, and there is abscess involving the left because TLC was high. If you recall your like history in the previous slide, TLC was high, so that's why the diagnosis was more going towards the lung abscess. So a cat attacked by the dog started showing dyspnea. So thoracic is as one. So here you see cavitary lesions, where you see the retraction of the lung lobe because of the, and here you see the cavitary lesions, two cavitary lesions here, two cavitary lesions. These are the thin walled. If you see, these are the thin walled, not a thick walled. So that's why these are the air bullae, not the abscesses. So air bullae will show up as a thin walled. These are thin walled. So these are the, so radiograph shows as a lobar retraction, red lines, red outline by the free pleural space, means the pneumothorax is there. But these round white color circles, these are, there is a traumatic lung bullae are there, traumatic lung bullae. So here you see, so retraction of lung lobe is as well. So this is another young cat which was hit by car, open mouth breathing. So you see there is a cavitary lesions here as well. If you see the cavitary lesions, here you see the cavitary lesion. Let me show you again. So let me show you here. Concentrate on this circle in this square, a red square. So yellow one, this one. This is a cavitary, thin walled. This is air bullae because of hit by a car. So there is a air has gone into the pleural space. So that show up as a lung bullae as well. Lung bullae. Even you can see here in the right, left lateral lung. That was the right lateral. Here is the left lateral. Here you see the lung bullae. So this is the lung bullae, and even you can see the retraction of the cardiac shadow from the sternum. This is also an indication that there is a pneumothorax as well. Pneumothorax as well. Here you see. Here is a pneumothorax. So the mild pneumothorax. So and the air bullae. So it means there is trauma to the lung, which led to the air bullae formation as well as pneumothorax. So this is a traumatic lung disease. So thin walled, so that's why it is called. So thick walled normally, the thin walled is air bullae, thick walled are normally suggest of abscess, granuloma or neoplasia as well. So this is how you differentiate between the radiographically by looking into these cavitary lesions, whether this cavitary lesion is because of lung bullae or because of neoplasia, granuloma or abscess. So a dog hit by car shows difficult in breathing, lateral and VD view. If you see, so you can see here, observe in this portion of the thoracic radiograph. If you see here, concentrate on this portion. So I'm going to highlight right now. If you see this one, so let me highlight. Here you see different lung bullae are there. You can see they are thin walled. They are thin walled, containing the air cavity as well. Let me highlight this portion. If you see, these are the lung bullae are there. It means there is a traumatic lung disease, and this dog is also having mild pneumothorax as well. If you observe here as well, there is air pocket present between the cardiac shadow as well as the sternum. So mild pneumothorax with multiple traumatic bulla. So this is the diagnosis for this X-ray. So you can see there is a pneumothorax indicated by the lung lobe retraction seen in the lateral view. So observe the radiolucent gray density seen between the sternum and the cardiac shadow. Numerous traumatic lung bullae are seen in both the views. So a 5-year-old dog is a febrile and having a non-productive cough. There is a no productive cough, is a febrile since last 3 weeks. TLC is raised, not satisfactorily responding to the treatment. So lateral and VD view is taken. If you look into this one, so this is if you look into, let's look into this one here. Let me highlight at this point. And in VD view, if you look into this point, so there is a lung abscess. That's why animal is not responding to the treatment satisfactorily. If you see lung abscesses are there, this is the cavitary lesions. So there are small air pockets are also present within these cavitary lesions here. These image lesions, well, so note the small air pockets within this one. So this is a typical the thoracic X-ray that show multi cavitary lesions, lateral and VD involving the right caudal lung lobe. And this is consistent with diagnosis of neoplasia, abscess or granuloma. As the dog is febrile, TLC is high, so suppurative infection can be the best differential. So I'm talking about this one, caudal lung lobe. So here is the caudal lung lobe, so which is having a lung abscess. So let's come to the fourth lung pattern. So fourth lung pattern is the vascular pattern. So fourth lung pattern is a vascular pattern. So vascular pattern is normally seen in heart disease only. Till now, I have discussed unstructured bronchial pattern, unstructured interstitial pattern, then nodular pattern, which can be, so out of these unstructured pattern, most of the pattern is because of the lung disease. But this vascular pattern, when vascular pattern is there, then this indicates that it is most likely is having a lung disease or lung failure, or sorry, not lung disease, or heart disease or heart failure. So for vascular pattern, a vascular pattern is present when amount of the blood in the large arterial or venous branches is increased or decreased. So this causes the vessel to change in size, shape, and direction. So this is the vascular pattern. So vascular pattern, normally the size is increased or decreased because the perfusion of the lungs is by the heart. So any alteration in the functioning, if any heart is not able to compensate, or heart disease is there, or there is overwhelming heart disease is there, which led to the heart failure. So there will be alteration in the size of the blood vessels. That is called a vascular pattern. Look into this one. So if you see, you have to listen my previous webinar as well. So that will show you like a lot of about the vascular pattern was taught in that webinar as well. So this is the lobar, cranio-lobar pulmonary artery. This is a vein, and here is the bronchi. If you see this structure, I'm talking about this structure. This one, this is a big vessel is there. Here is this big vessel. But if there is here is the aorta and caudal vena cava. So whenever you look for the vascular pattern, you have to see about these vessels. You have to look for these vessels. So if there is an increased size of lobar vein, I'm talking about this vessel. So if there is an increased size of the lobar vein is there, it means there is a pulmonary congestion. When there is a pulmonary means you have to compare the size of the lobar vein and the artery with fourth rib. I'm talking about this fourth rib. So the size of the fourth rib and these both vessels should be same, or it should not be, means like these the vessel vein as well as the artery, the size should not be more than fourth rib diameter. If vein is bigger than the fourth rib, that indicates it is a left side heart failure in that particular dog. And if there is an increased size of the cranio-lobar artery, upper one is the artery, lower one is the vein. So if there is a bigger, then it means heartworm infestation is there. So if increase in the size, if both pulmonary artery and pulmonary vein is bigger than the fourth rib, that indicates is a patent ductus arteriosus is there, bigger than the, so I'll show you the X-ray as well for patent ductus arteriosus. So then there is a decrease. If there is a decrease in the size of pulmonary artery and pulmonary vein as compared to the fourth rib, it means there is underperfusion or hyperperfusion of the lungs is there. So then it is a case of pulmonic stenosis, or it can be because of dehydration, or it can be because of the shock. If animal is not dehydrated or not in a shock-like condition, but there is a decreased size of the lobar arteries and vein, it means that can be the pulmonic stenosis can be the diagnosis. So increase in the size of caudal vena cava, that indicates the right side heart failure. Means the right side heart failure, there will be increased size. So left side heart failure, there will be lobar vein will be bigger than the fourth rib. So these are the diagnostic point. So when you look for vascular pattern in a thoracic X-ray. So let me highlight. So this is the X-ray, which is the dog, which is having left side heart failure. So left side heart failure means how we can judge. So looking at the vascular pattern. So let me highlight this portion. If you see this portion, this is the pulmonary vein. This is the pulmonary artery, and here is the rib. And if you see the size of the pulmonary vein, and this is the pulmonary artery and size, if you look into the pulmonary vein, the size of the pulmonary vein is bigger than the rib. So it means there is a pulmonary congestion, and this is because of left side heart failure. So this is a normal. You can compare with the normal reference. You can see the size. Here the size one, this one. This is the pulmonary artery. This is pulmonary. This one is pulmonary vein, and now is the pulmonary artery. So the size as compared to the fourth rib is normal. But when there is a left side heart failure, so size of pulmonary vein will be the bigger. Now clinical size cases having the vascular lesions. A beagle 1.5 year of age is recently presented to our hospital with the exercise intolerance. So there was ascites as well. So on physical examination, murmurs are observed in the left near the base of the heart. So radiography when took, there were few changes were there. Vascular pattern was seen. Here you see there was a vascular pattern. If you look into this one, so there was enlargement of the left atrium as well. So here is enlargement of the left atrium and the pulmonary vein, and here is the pulmonary artery. Both were bigger than the rib, fourth rib. So there it means there is hyperperfusion of the lungs. So this led to the increase in the size of both vein, cranial lobar vein, as well as artery. So this is a clear-cut indication the dog is having PDA, patent ductus arteriosus. So enlarged both pulmonary artery and vein as compared to the rib size indicates overperfusion of the lungs. So most likely diagnosis is patent ductus arteriosus. So a dog which is 80 years of age is presented with exercise intolerance, resting most of the time, open mouth breathing on minor exercise. So thoracic is as follows. So this is a case of hypoperfusion. If you see in a VD view, the blood vessels, especially if you see these blood vessels, these small blood vessels, these small caudal lobar vessels, if you compare with the rib, they are smaller than the rib. This is because of the hypoperfusion. It means the lung is not getting enough blood. And there is another thing is which is visible. So you have to see at this point. So you have to compare, you have to see at this point. There is a bulge. Here is the bulge as well. So when you see this bulge, so let me show you that this is a diagnosis of pulmonic stenosis. Let me show you here. When I extrapolated the X-ray with the normal, you see there is enlargement at 1 o'clock to 2 o'clock position. So this is all because of pulmonic stenosis, which led to the enlargement at 1 o'clock to 2 o'clock position, and this is a position of pulmonary artery. And let me come back to this one. So in VD view, so observe the caudal lobar vessels. They are smaller than the normal, and it is underperfused. You can see whole of the lung lobe. Here you can see the left side lung lobe, right side lung lobes. The vessels are not clearly visible. Vessels are not, it looks like all air. Most of the air is present, but vessels are not, means it's underperfused lungs. These are underperfused lungs, these vessels. When these vessels, you can compare the size with the ninth rib as well. The size is smaller. So you can observe 1 o'clock to 8 o'clock position. So all these radiographic findings, they goes towards the pulmonic stenosis. So here fifth lung pattern, which I'll be discussing right now, is alveolar pattern. So alveolar pattern is basically an advanced form of unstructured interstitial pattern. Advanced form of unstructured, the same way if you see, so let me discuss the same structure. If you see these, when the alveolar air space, when these alveoli, earlier what happens in unstructured, this portion of interstitium was having a fluid. Now what happens if this case is long standing, as in is not treated properly? Just for example, I told you one of the cause of unstructured interstitial pattern is left side heart failure. Just suppose there is a scenario is there, the dog which was having interstitial pattern and owner ignored it and doesn't went for the treatment or went to the vet but has not followed the protocol, but slowly so there was interstitial pattern, unstructured means fluid was there in the interstitium, but now what happens if it becomes a long standing, no treatment, slowly the fluid will start entering into alveoli. When the fluid will start entering into the alveoli, so the alveoli will start filling with the fluid. Now the bronchi will have air, but the alveoli will have fluid in it. So bronchi will be clearly visible. So that is called air bronchogram. When bronchi have air, but alveoli has fluid. So unstructured interstitial pattern ultimately, when it is not treated properly, can lead to alveolar pattern. So when alveolar air spaces between becomes fluid, filled with the fluid or cellular debris or alveoli becomes collapsed, so that becomes a solid opacity and alveolar pattern is present. So there alveolar pattern is three types. It can be air bronchogram when bronchi has air, alveoli has fluid. Celotti patterns means when even the bronchi, though now the case is still long standing, so now the bronchi will start having the fluid in it. Now the air space in the air inside bronchi will be occupied with the fluid, then it becomes a lobar pattern, means whole of the lobe of the lung will be filled with the fluid. So that is an advanced stage of alveolar pattern. That is also means air bronchogram, Silhouette effect, and lobar signs. These are the indication of alveolar pattern. Means this is first. These red arrows, they indicate that when the fluid enters into interstitium, which is unstructured interstitial pattern, but later on but later on when it is not treated properly, so the fluid enters into the alveoli. But there are some other conditions, non-cardiogenic in origins, which I'll be discussing, which can directly lead to the alveolar pattern as well. So I'll be discussing in those case studies as well. So here the whole of the lobe will be having fluid in it. So the alveolar pattern, which ultimately, initially it will be, this is air bronchogram. Air bronchogram means these bronchi will have air, surrounding alveoli will have water in or fluid in it. So this is unstructured interstitial pattern because of the left side heart failure. So now the bronchi, whole of the bronchi, even the bronchi have started having a fluid, whole of the alveoli, they have fluid in it. This is called Silhouette effect. Only bronchi is visible. Only bronchi is visible. Here it is, only bronchi. So this is typically, you can see only bronchi. All the bronchi, they are surrounded by the fluid in the alveoli. This is called alveolar pattern. This is a typical sign of pulmonary edema, which initially was unstructured interstitial pattern. Now it has become alveolar pattern. Here you see the alveolar pattern. And the next slides, if you see, here it is. So it looks like a root of the trees. It looks like a root of the trees. If you see at this point, if you see all these, if you observe these circles, if you see all these are all bronchi, big bronchi. These are the big bronchi, and which is surrounded by the alveolar tissue, which is all filled with the fluid. These are all. So here you can see as well. So these are all big bronchi. Means air is present only in the bronchi, and there is a very good contrast between air in the bronchi and the fluid in the alveoli. So that led to this is called air bronchogram in the cranial, right, middle, and caudal lung lobes. So there is if the case becomes advanced, then slowly that fluid will start coming into the bronchi, then whole of the lung lobe, this will be affected, and it will show up as a lobar. This is called lobar sign of alveolar pattern. Lobar sign of the alveolar pattern. So here you see the lobar pattern. Here you see the whole of the right middle lung lobe, middle lung lobe. So you can see this accessory lung lobe. Accessory lung lobe is normal, but right middle lung lobe, it is having the lobar signs. It is alveolar pattern as well, and even you can see at here this one. Sorry. Yeah, here you see these bronchi are visible, but this is surrounded by all alveoli, which is having fluid in it. So this is alveolar pattern. So this is alveolar pattern can be initially shown up as the air bronchogram, then Silhouette effect is there, then lobar signs. Lobar signs means whole of the lung lobe is filled with the fluid. So here you see the white arrows, these white arrows, these ones, these indicates lobar signs, mean lung lobe, whole of the lung lobe is filled with the fluid. But here you see this one, I'm talking about this one, this cranial lung lobe is having air bronchogram. Air bronchogram means you can see here the bronchi has air, but is surrounded by all those structures, all surrounded by the alveoli, which is filled with the fluid. So here you see, here what I'm talking about, this is alveolar pattern, air bronchogram. So this is a diffuse alveolar pattern. So whole of the lung is lung lobe, most of the lung lobes, they are filled with the fluid, means this is an severe case of pulmonary edema is there. So pulmonary edema, one of the reason can be cardiogenic and it can be non-cardiogenic reason as well. Liver disease, hypoproteinemia, if there is an electric shock is there, or there is some drowning history of the dogs, that can also leads to the alveolar pattern as well. So air bronchogram, if you see VD view, if you VD view, the trachea is visible. If you see the trachea is visible, here you see the bronchi is also clearly. In a normal X-ray, you can't see such type of clear bronchi as well. Here you see the bronchi. This is called air bronchogram. So this is an air bronchogram. So differential diagnosis can be, so whenever there is a bronchopneumonia, just for example, if a lung lobe is affected, which is having a bacterial infection, so there is a localized lung infection is there. So that will show up as a alveolar pattern, bronchopneumonia. Edema, so normally cardiogenic edema especially, or any other edema, mostly which is located in the chordodorsal part of chordally lung lobe, which is near the diaphragm. So hemorrhage can be there. So even that can show up as an alveolar pattern within the lung lobe. There is a hemorrhage is there, but usually it's asymmetric. So depending upon the trauma. So lung collapse can be there, but there will be a mediastinal shift, means mediastinum will be shifted to opposite side if there is a lung collapse is there, or primary lung tumor that can whole of the lung lobe is having a tumor. So that will show up as a lobar sign. So let's come to the clinical cases of alveolar pattern. So clinical cases is a 6-month-old puppy. So 6-month-old puppy that chewed a live wire connected to the air conditioner. Now the puppy is having a difficult breathing. So radiograph of the thorax and VD view is shown as what is the lung pattern. If you see, let me highlight this portion, caudal part of the hair. If you see this portion, this is caudal lung lobe. So if you look into this one, if you see these are the big bronchi. Here are the smaller bronchi. But these smaller bronchi, very good contrast. Normally it's not visible. Why it is visible? Because alveoli, all edematous, are having a fluid in it. This is called air bronchi, a bronchogram. Here too, if you see, look into this one. So here the air bronchi, this is the air bronchogram. Here is the air bronchogram. So here too, the air bronchogram is there. Here you see the air bronchogram. These are all bronchi containing the airs. So radiographic sign is, so electrocution will convert the electric energy into heat and will disrupt the pulmonary vessels, leading to increased pressure and fluid leakage into the lung tissue, a condition which is called neurogenic or non-cardiogenic pulmonary edema. It means electric shock can lead to alveolar pattern. So the electric injury can cause damage to the alveolar wall, leading to the bleeding within inside, and that can also show up as a alveolar pattern as well. So drowning can also lead to the alveolar lung pattern in the cranioventral in the cranioventral lung lobe. If same alveolar pattern and drowning history is there, so it means that alveolar pattern will be shown up in the cranial lung lobes as well. Because whatever when drowning, whatever the water goes into the air passage with because of the gravity, it will settle into the cranial lung lobes only. It will not go to the caudal lung lobes as well. Same way happen because of aspiratory pneumonia. If there is aspiratory pneumonia is there, so if animal aspirate anything, so that aspirate will go into the cranial lung lobes only, and pneumonia will happen in the cranial lung lobe only. So that's why any pneumonia, bronchopneumonia, so in the cranial lung lobe, that will be because of the infection in the lungs only. That is not because of any other systemic disease. A 5-year-old dog developed nasal discharge 1 week ago, dyspnea on coughing. 2 lateral and VD were taken. So here it is. So this is you can see here there is a, if you see the this is a right lateral view and this is a left lateral view. In left lateral view there's a clear lung lobe is visible. So here there is a right middle lung lobe. Here is the right middle lung lobe. There is a right middle lung lobe, and this one is accessory lung lobe. So A is accessory lung lobe. You can see the demarcation. So demarcation between the right middle lung, it means there is a lobar sign is there between the right middle and the accessory lung lobe. So this indicates, so here you see the right middle lung, VD view, if you see, it's all congested. So this indicates chances of pneumonia can be there. So here you see, so there is alveolar pattern. This is alveolar pattern, lobar consolidation. Means this is the advanced stage of alveolar pattern. So lobar sign is there, which is involving the right middle lung lobe. So ventral location of the alveolar pattern is consistent with pneumonia. So in lobar sign, that too in the cranial lung lobe or right middle lung lobe. So that is mostly consistent with the pneumonia. So whereas caudodorsal lung lobe alveolar pattern, that is consistent with heart failure. So here is the two differential sign. Means cranial lung lobe or right middle lung lobe, lobar alveolar pattern means chances are there that pneumonia can be the most likely cause. And if it is caudal lung lobe, means I'm talking about this one, if here it is the problem, then alveolar pattern is there, then chances of consistent with the heart failure. So a lateral ear canal ablation was done in a golden retrieval 12-year-old 1 week back, now presented back with coughing and fever. So lateral and VD view which is taken. If you look into this one, if you especially look into the cranial lung lobe, and here I'm talking about, if you look into this one, this is air bronchogram which is involving. It means this dog is most likely affected with the pneumonia. Here, if you see, concentrate on this portion. Here there is alveolar pattern in caudal lung lobe as well. So here you see it's a clearly visible. So clearly visible bronchi, which is going towards the cranial lung lobe. This is called alveolar pattern. This is alveolar pattern. So here too, if you see the alveolar pattern, so here too the alveolar pattern is there. To concentrate on this one. So there is a severe alveolar infiltrate in the right cranial, middle, caudal lung lobe with mild involvement of the right middle lung lobe as well. So alveolar infiltration is observed in the ventral dependent portion. So means you can observe how much changes are there and extent of changes are there. So after treatment, you can monitor the changes as well. If there is an improvement, you're responding to treatment, so the lung pattern will also improve. So these changes are typical of pneumonia. So a 16-year-old Dachshund with a history of exercise intolerance, but becomes severely dyspneic last night. So next slide will show the thoracic, what are lung pattern and what are radiographic diagnosis. So here you see, so this is the one view, right lateral, left lateral, this is right lateral. If you see the caudodorsal lung lobe, if you see the caudodorsal here, concentrate on this portion. So if you see there is a one lung lobe is going, this bronchi is going, and here it is. There is one bronchi is going to this one. It means bronchi are highlighted because of the fluid in the alveoli, and this is the alveolar pattern, and this is so this Dachshund was having pulmonary edema, which is shown up as an alveolar pattern, and that's why this disease was diagnosed as left side heart failure, and that left side heart failure was the cause of alveolar pattern. So here too, if you see this one, this is the same dog which is having now you can see the bronchi running caudally as well, caudal lung lobe, and having increased radiopacity. This is all because of the pulmonary edema. This is all pulmonary edema. So note the chorodorsal location of the alveolar disease, typically found in the pulmonary edema. So this is typically air bronchogram is very clearly visible in the caudal part. So this is a typically sign of a generalized there is a generalized cardiomegaly as well. If you see the position of the trachea, here is the position of trachea is pushed upward. It means there is a big heart which is pushing the trachea upward. Alveolar pattern is there. It means cardiomegaly. There is an increased cardiac shadow as well in the lateral view, and pulmonary edema. All these indicates that cardiomegaly is the cause of alveolar pattern which led to the pulmonary edema as well. So 11-year-old female Pomeranian presented to you with non-responsive soft cough at night, exercise intolerance. On exam, she has a tracheal sensitivity, murmurs, femoral pulse are strong with regular rhythm. So here you see the radiographs, lateral as well as VDV. Just concentrate on the caudal lung lobe. See the bronchi are clearly visible. This is a typical sign of alveolar pattern in the caudodorsal lung lobe. And even you can see the cardiac shadow is bigger, trachea is pushed upward, and even I can see the vascular pattern as well. So vascular pattern means I can see the vessels here, these pulmonary vessels, these pulmonary veins especially is unlined, bigger. So alveolar pattern and vascular pattern both are present in this. So you can diagnose this one as a mixed alveolar pattern, mixed lung pattern as well, which is because of the cardiac failure. Here you see the vein is bigger than the rib, and here if you see, let me highlight this one. Even you can see, you can measure the VHS vertebral heart score, which will be more than 10.5. Cardiomegaly is there, and see how the trachea is traveling. It is traveling caudally as well as dorsally rather than ventrally. So here is, so it is pushed upward, and even there is a hepatomegaly. This is all sign of heart failure, and the reason for these alveolar pattern in the caudal lung lobe is because of the heart failure. So here it is. Here is the lung alveolar pattern is there. So the lung, there is bronchi are clearly visible in the caudal lung lobe as well. So even in the cardiac shadow as well. So these are all indicate that there is a left ventral enlargement, left side enlargement, and left side heart failure. All these. So liver. So even this is a congestive heart failure. This animal is going towards congestive heart failure as well, because hepatomegaly is also developing. When hepatomegaly is there and alveolar pattern is there, it means animal is going towards congestive bilateral biventricular heart failure is there. So all these run. So all these vessels, especially the caudal lobar vessels. So you can see this is these vessels, especially the vein, caudal lobar vein is bigger than the rib, ninth rib. So it means this is a sign of pulmonary congestion because of heart failure. Now comes to the last pattern, which is a mixed pattern. So mixed pattern is a lung disease consists of general specific, means it can contain more than two patterns. Vascular, alveolar pattern can be together. It can be unstructured interstitial pattern as well as the bronchial pattern can be together. So more than two patterns, when they are present in the same X-ray, then it is an indicator that is a mixed pattern. It can be generalized or specific. Means all pulmonary pattern usually have a component of another pattern also present, but to lesser extent. In this case, the pattern which is predominant. Just for example, if alveolar pattern is predominant than the bronchial pattern, then we should concentrate or formulate the diagnosis according to the alveolar pattern rather than the bronchial pattern. So in specific, some of the diseases may occasionally present as a two pattern which is a similar magnitude. Sometimes the two patterns of similar magnitude are present. So these are normally when there is a granulomatous pneumonitis is there, or heartworm is there, or some occasionally neoplasia like lymphosarcoma is there, or there is some metastatic disease is there. So then they can show up as a similar pattern as well. This is called specific lung disease. So here, if you see, look into this pattern. Here in this portion, this one is the aspiratory pneumonia. So when this aspiratory pneumonia is there, this will show up as an alveolar pattern, or even the unstructured interstitial pattern. Here, the caudal lung lobe, if you see, there is a pleural pneumonia is there. Here, if you see, there is an alveolar pattern, and here there is a bronchial pattern. pattern. You can see like more than 2 patterns are present, or 2 or more than 2 patterns is present in the similar. So this is called mixed pattern. Then you have to write down in the report that which pattern is predominant, like this one. In this, all the pattern are of a similar pattern. Then you have to write down that bronchial, alveolar, as well as unstructured interstitial pattern, all are of similar percentage are present in the thoracic cavity. So other clinical signs, so let me discuss. There are a few other clinical signs which can affect clinical cases which can affect the pleural space and mediastinum. I'll be discussing a few interesting cases as well in addition to these patterns. So a stray dog which was presented as a history of difficult breathing. Recently, it was presented to us, and it has a fight, and there was a deep bite wound near the thoracic inlet. I told you in the beginning of my normal radiography, normal thoracic radiography, that there is a cupula pleura, there is a structure is there in the cranial part of the thorax, which is communicating with the thoracic inlet, and part of the pleura will be into the thoracic this neck area as well. And whenever there is a fight or there is a bite is there, and deep bite wound in the thoracic inlet, then air from outside can go into the pleural space as well. So there is physical examination, there is a muffled heart sound. Thoracic radiography is as follows. You can see there is no thoracic trauma. Only trauma is at the level of neck. So at the level of neck. So at the level of neck, pleural space as well as mediastinum, both are communicating with the neck. So next case, I'll be showing you the case in which there will be fight that led to the pneumomediastinum. I'll show you that one. But this case is because of the fight, there is a rupture or puncture of the cupula pleura, which led to the air entering into the pleural space, which led to the pneumothorax. Here you see the pneumothorax. So here the collapsed lung lobe, there is a caudal lung lobe is collapsed because of the surrounding air. And this is you can see there is a big air pocket between the cardiac shadow as well as the sternum, and the retraction of the lung lobe is there. So this is a typical sign of retraction of the pleural space away from the chest wall, and there is a space is there. This is a typical sign of pneumothorax. This is why I want to show you this one, because the trauma was not in the thorax, it was in the neck area. Because of the cupula pleura rupture, so air has entered into the pleural space. So sometimes you have to see that history may be that owner will say that there is a fight is there and there is some wound is there. So sometime when you look into the X-ray, there must be some thoracic trauma. So this is not a thoracic trauma. This is trauma in the neck which led to the pneumothorax. So there is another interesting case. This is probably the last case, clinical case. A dog which is hit by a car become unconscious after head injury. So thoracic radiography was taken like this. So there is all like a lot of radiopacity, increased radiopacity, and you can see this is a pneumothorax. Retraction of the lung lobe is there. Alveolar pattern is there. So showing this edema. If you see that the edema in the caudal lung lobe is neurogenic in origin, not cardiogenic in origin. So edema, you have to correlate with the history. If there is a history of that is going towards the cardiac patient or heart patient, then this edema will be, or alveolar pattern or pulmonary edema will be because of cardiogenic in origin, but this is because of neurogenic in origin, or even because of the pulmonary hemorrhage as well. So last case, this is a dachshund which is attacked by the big dog. There is a multiple deep bite wound in the neck. So dog started with the mild, started showing mild dyspnea. Thoracic and abdominal radiography is as follows. So you can see that there is an air pocket is there. So here, this is the case of pneumomediastinum. So neck area, neck area, there are even the pleural cavity which is also communicating, and even mediastinum is also communicating in the neck. So fight with the neck, sometimes air can enter into the, so trachea is, you can see the trachea is outlined by the air. So there will be neck and subcut space. Air is there. If you see the subcut air, here the subcut air is there. So this is all because of fight, and this is a pneumoperitoneum, and this is a pneumomediastinum, not pneumoperitoneum. This is pneumomediastinum. Sorry. So pneumomediastinum, you can see clearly that this aorta will not be clearly visible, because I told you aorta is present in the mediastinum. So trachea is also present in the mediastinum. So when the air which enters into the mediastinum will highlight all the structures, because there will be very good contrast in the mediastinum. So you can see clearly the aorta which is entering into the retroperitoneal space. This is the retroperitoneal. So cranially, mediastinum will be communicated with the thoracic inlet. Caudally, the mediastinum communicates with the retroperitoneal space. If the air enters into the mediastinum, that will likely enter into the retroperitoneal space as well. So here, this is the next X-ray, same X-ray. So you can see the air is there in the retroperitoneal. Here is the retroperitoneal space, and kidneys are so clearly visible. Normally, the kidney will not be visible in X-rays, but it's visible because this kidney is surrounded by the air, and that led to the very good radio contrast. So kidneys are clearly visible. Even you can see the aorta which is going from the thorax into the abdomen, which is surrounded by the air. And this is the case of pneumomediastinum. And when we took the X-ray of the neck, there was air in the neck muscles as well. And that air entered through the thoracic inlet into the mediastinum and ultimately into the retroperitoneal space. So let's conclude from my presentation. So if we conclude is the history and physical examination findings are important before evaluating the radiographic changes. Bronchial pattern predominantly seen in the cases having respiratory disease. Unstructured interstitial alveolar pattern can be cardiogenic or non-cardiogenic in origin. Nodular interstitial pattern may indicate metastatic or primary lung disease. Vascular pattern is seen in heart disease and heart failure patients. So these are my conclusions. So that's all from my side. Now I'm open for the discussion if anybody having any query. So I'm happy to answer. Thank you, sir. Hello.
Thank you very much, sir. It was a really amazing experience and amazing session. The only thing is there has been some problem. Somebody has opened the RTT today. That is a new feature added to the Teams, where we can see the live captions of the meeting. So the AI agent transcribe whatever you are saying. Somebody has opened it. So there is a small window opening at this. I hope in the recording it will not be there. So I'm really sorry for the glitch happened due to somebody's mistake. But I think session was fully engaging. Even 172 vets are still here. More than 200 vets were there present in the by the end of this session. Some vets were saying that it should be on a holiday because these are long sessions. So let's keep it on the weekend or maybe on the Sundays. Next time we can
see.
Keep it on the Sunday.
Definitely. Yeah. Okay, so there are a few questions are there. Yeah. Should I take the queries?
Sure, sir. Sure, sir.
Yeah, thank you. Let me take the queries one by one. So if there is one question is there, how to differentiate between a pneumothorax and pneumomediastinum. So last two slides I showed you the pneumothorax. When there is a pneumothorax is there, then that heart will be lifted from the sternum. So there will be big air pocket just ventral to the heart cardiac shadow. But when there is a pneumomediastinum, then heart shadow will be in that's a normal place. Pneumomediastinum, then the aorta, then this trachea. That will be clearly demarcated, and that aorta will be going into the abdomen, into the retroperitoneal space, and into the retroperitoneal space we can clearly see the kidneys are there, because kidneys are present in the retroperitoneal space and air will be present around the kidneys. So that will make a very good contrast, and kidney margins will be clearly visible, which are normally not visible in a normal X-ray. So this is how you can differentiate between pneumomediastinum and pneumothorax. Yes. Do meloxazothioprine, cyclosporin work equally well to reduce the lung inflammation instead of steroid? Steroids we are giving meloxicam may not work in. I have given you the shown you the X-ray which are pulmonary infiltration of eosinophilia. That was allergic in origin. Normally allergy steroids. Normally we might have to give steroids as a first drug of choice. So slowly and slowly we have to taper that or other immunosuppressant drugs you can give. You can give you talk about the azathioprine or cyclosporin, but those are little bit costly drugs. You can try those ones as well. But first, mostly steroids or prednisolone is the first drug of choice, especially when there is a pulmonary infection or severe bronchitis is there. Okay, there is. Okay, let me question because this is all real time probably. It is taking most of the screen space. Okay,
Yeah,
what
these
percent?
are the
Yeah.
complaints.
What could be the satisfactory treatment of the lung abscess? Yeah, this is very good question. Lung abscesses we are treating at our place. So what there is first you have to start with the antibiotics and see whether it's responding to the treatment, because there is a lung is a very vascular structure. So antibiotic, most of the antibiotic likely it can go up to that infected portion as well. So you can start with the antibiotic, higher dose of the antibiotic, but you have to continue for the long term, maybe for 15 days, maybe for 21 days, and see you are repeatedly you have to go for X-ray whether the size of that abscess is going down or it is animal is responding, TLC is going down. If it doesn't, then you might have to aspirate for percutaneously. Sometimes you have to aspirate, or for that you might in advanced stage which is not responding, you might have to open up the thorax as well. For thorax you have to open up and then you have to aspirate and you have to break the pyogenic membrane as well. So change the timing of webinar. Okay, we'll consider. Okay. So RTT glitch is there. How to differentiate between pneumothorax and mediastinum? Pneumomediastinum already discussed. How to decide when to go for thoracic tapping? Thoracic tapping we can go whenever there is pleural effusions are there, or pneumothorax is there, or pericardial effusions are there. So these three conditions you can go for thoracic tapping. So screen look okay to me. Then request everyone to check 3 dot. Okay. Okay, we are not able to see. Okay,
We were trying to rectify the
communicate
glitch
at that time. Okay. Excellent presentations. Okay, thank you very much, sir. So I'll take it as a compliment. Why were the recommendation for the patient in cases metastatic, pulmonary metastasis observed? Yes, this is a very good question. So pulmonary metastasis, first of all, what we follow at our place is whenever there is pulmonary metastasis there, then we try to find out whether this is a primary tumor or it is because of metastasis in a region. So if it is a primary tumor, whether it's a solitary tumor or it is covering most part of the lungs. If it is a solitary tumor, then we can go for resection of that particular solitary tumor. But if it is a multiple tumors are involved, then it may not be possible to resect all these. Some of the vets, they are trying for chemotherapy, but I will highly discourage this practice because chemotherapy may not help because most of the tumors of the lungs, they are malignancy in nature, and further it can deteriorate the health as well. But if it is a primary, not as a metastatic in a region, then we have to see what is the source of metastasis. So most common source of metastasis to the lung is splenic tumor, or even liver tumor as well, but splenic tumor is the most common cause. So that's why splenectomy has to be done, and then monitoring has to be done. Repeated monitoring has to be done. That whatever the metastasis has done, it may not grow back. But if it starts growing, then we are not helpless. We are helpless. Then we might have to go for euthanasia in such patients. But if solitary tumors can be removed. So conclusion slide, please show it again. Okay, I'll show it again, no problem. Sir, the case 12 should look like a hard boot-like. No, that was not a boot-like. The case 12, that was pulmonary congestion was there. Boot-like is mostly whenever there is a heartworms are there. Heartworms are there, which I previously showed you in the previous webinar. Heartworms are there whenever there is a right ventricle enlargement is there, and there is a pulmonary artery enlargement is there. So it was not like that. Let me see. Is it possible to differentiate between the lung lobe collapse and severe lung lobe sign as well? This is a very good question. Somebody might have read before. Yeah. So how to differentiate between lung lobe collapse and severe lobar sign? Lobar sign, normally they will have a little bit alveolar sign as well. Means the bronchi, they will be running towards the periphery of the lobe as well. But when there is lung lobe collapse, or you can say lung lobe torsion is there, then the bronchi will suddenly stop. Blind end of the bronchi will happen. So that means the lung lobe torsion has happened. So along with the torsion of the lung lobe, the torsion of the bronchi has happened. So bronchi, blind end of torsion. But if there is an alveolar pattern, then the bronchi, they will be running till the end of the lobe. So this is how you can differentiate. Good evening. I have one doubt: how to differentiate between the fungal infection and small nodular interstitial pattern. Small nodular interstitial pattern will not look like a cotton ball-like appearance. I told you it looks like a cotton ball-like appearance. So fungal infection will look like a cotton ball-like appearance. Nodular interstitial pattern will show up as a structured pattern. This is fixed structure pattern. There is no other pattern is there, structured nodular pattern, but cotton ball appearance will be absent in the nodular interstitial. How to differentiate between the miliary TB? TB is very rare in pets, right? So TB is not so common. It's more common in cows and buffaloes, and human. TB is not so common. Miliary pattern can be because of some hemangiosarcoma, or it because of the metastasis from hemangiosarcoma of the spleen, or can be because of the lymphosarcoma as well. So how? So there is how to differentiate between the miliary TB, nodular pattern, and infectious this leptospira. Leptospira serovar, they will show up as a alveolar pattern. So alveolar pattern and nodular pattern, these are two different patterns. So which I already discussed in the webinar. How to differentiate asthma and lungworm. Asthma in cats will have basically lungworm can be the cause of asthma. Asthma is a sign. This is not a disease, any causative agent. Asthma is a sign. Sign means that there is expiratory dyspnea, flattening of the diaphragm. There is an increased size of the caudal lung lobe. So these are all signs. This sign can be because of any allergen, and this allergen can be lungworm as well. Please explain a barium study of extrathoracic. Okay, that's fine. This case which I discussed is basically when we took a lateral view, there was no nodule was seen. But when we took a VD view, it looks like there is one nodule is visible. So when we did a thorophysical examination, there was another nodule was visible in the sternal region, in the sternum. So in order to differentiate whether there is another nodule, extrathoracic as well as intrathoracic, two nodules are present or one nodule is present, then what we did, we applied barium on extrathoracic nodule, and then we took an X-ray, and when the barium was was visible only in one nodule, which is extrathoracic, then we were able to differentiate that there is no intrathoracic, it is only the extrathoracic nodule which was shown up in the VD view. Okay, so a lot of appreciation. Thank you. Is there anything like antibiotics of my amoxicillin, clavulanic acid, or even cephalosporin group that can be used. But presently, I'm using mostly the injectable if there is a bacterial, because they have a more tendency to go into the pulmonary tissue. Okay. Okay, Dr. Anand, like it's always wonderful to learn. Excellent. Thank you. Thank you. So nice. Happy teachers. They're so nice. This is my student Sheetal Dogra. I really appreciate. Thank you very much. How to radiograph differentiate between fungal metastasis? Fungal metastasis is not there. Fungal metastasis, there is no disease of fungal metastasis. Or you must be talking about the systemic fungal disease, which has gone into the lungs. But systemic fungal disease is rare in India. It is mostly present in Michigan, or there is one area is there in Colorado state where the systemic fungus is there. But in India, like systemic fungus, you're talking about aspergillosis, coccidioidomycosis. So these type of fungus are rare in India. Although, like if there is some dog which is imported from their area or shifted from there to India, already having fungal, that may be the different thing. But osteosarcoma, you're talking about fungal metastasis and osteosarcoma metastasis. Osteosarcoma metastasis will be shown up as a nodular pattern, and fungal metastasis will show up as a cotton wool-like appearance. Can you please explain retraction of the lung lobe once again? Retraction of lung lobe means when there will be air in the pleural cavity. Air enter into the pleural cavity, that might be because of the thoracic trauma or bite wound from the neck area. When it has gone into the pleural, so when air enters into the pleural cavity, it will push the lung lobes away from the lateral aspect. So when it pushes, so that will show up as a pneumothorax in an X-ray. That is shown up as a retraction, because there will be retraction of lung lobes because of the air in the pleural cavity. Okay. Thank you, sir. Thank you. All these are all most of the questions. Further recommendation of hypertrophic osteopathy. Yes. So I told you that etiology is not the long bones. Although there are signs are there, hypertrophic osteopathy is there, but the etiological agent is present in the thoracic as a pulmonary osteopathy. Means you have to remove that mass. So slowly and slowly, those signs will regress. So my idea of showing the video is that if you see any hypertrophic osteopathy, don't limit yourself to the long bones. Try to see into the lungs as well. Hats off to Stamina on lecturing for so long. Thank you very much. So we are paid for, means because being a professor, so we usually take the lecture for quite long, and this is our duty. Thank you very much. Is a hypertrophic osteopathy rare? I'll not say rare, but occasionally the cases will come. Normally the fast-growing breed, fast-growing breed, they can be presented to your place as a hypertrophic osteopathy. So history will be difficult breathing sometime, and difficult breathing will be there, and the limbs will be huge, big image. And when you take an X-ray, I have already shown you there will be a periosteal reaction, severe periosteal reaction will be there. Okay, sir. I think probably I have done with all my queries.
Yes, sir. So, sir, first of all, I don't. This was really a very wonderful session. Why? Because I know it is a very interesting topic, and this topic and abdominal X-rays, these are like, in limbs, and it is very clear.
Yeah.
Far more clear. But when we
Yeah.
talk about the thoracic, and when we talk about the abdominal X-rays, these are big puzzles. And every day we see, and every day we find out something or the other thing new. So this was truly engaging, sir. From the team of Orihill Life Sciences and from the side of all the attending veterinarians, we thank you a lot from the core of our heart. You took so much time and explained everything so well that we can use this knowledge from the very next day to in our practice. And thank you so much for inspiring us and making us understanding towards radiography. And we'll be expecting more and more sessions from your side, sir. Please spare time as soon as possible so that more and more sessions can be arranged. So thank you so much, sir. It's
So nice.
always an experience learning from you, sir. Thank you so much.
Thank you, sir. Thank you, Dr. Vishal. I really appreciate that you gave me the platform to interact with our vets from all over India, so I can share so that our patients can be saved.
Yes.
So diagnosis can be made so that we can save our patients. So this is our motive.
Right, sir. So the next topic will be, sir, somewhere around. I mean, it is abdominal.
GIT radiology, sir.
Pardon, sir?
GIT radiology.
GIT. Sir, can we cover a little bit of barium meal? How to do that?
I will cover barium meal in that GIT radiology. Yes.
Because it is very much required in.
Yeah. So I'll include even the case histories as well, case studies, which is commonly misdiagnosed at field level.
Right, sir. Thank you so much, sir. Have a wonderful evening, sir.
You too. Bye.
Thank you.
Most trusted pharmaceutical company for companion animals of the year goes to Oriheal Life Sciences Pvt Limited, Dr. Vishal Sharma from Oriheal Life Sciences Pvt Limited.